So vascular amputations are a horrific thing for the patient, and indeed they're very anxious before it, and it's up to us as clinicians to try and get them through that process. As surgeons, we need to handle the tissues with care and optimise hemostasis to reduce hematoma and subsequent infective processes. Dog ears are unacceptable if you want to have an end-bearing prosthesis in that amputated limb. You want to protect good quality skin and cover the stump without tension. Bone edges should be smoothed, and you want to think of how the patient's going to use their stump for future prosthetic use. And tourniquets are used as per surgeon preference, particularly in orthopedic departments where they normally have adequate blood supply. We want to try and optimise wound healing with appropriate patient workup and antibiotic prophylaxis. I do tend to sometimes continue antibiotics for 48 or 72 hours if the limb is grossly infected or it's a revision of an infected prosthesis. You want to try and optimise patient physiology, and your operative technique has to be of a very high quality standard. You can do amputations at various aspects in the limb. For us in vascular, generally if we start distally, metatarsal amputation, a below knee amputation, more recently through knee amputation, and above knee or transfemoral amputations are the common ones that we do, along with toes or digit amputations. So how are we actually doing? Well, I used to work in England in the Royal Blackburn Hospital, which is part of the East Lancashire Hospital Trust. I quickly identified that we had a really big diabetic foot problem, and as such we needed to do something about it. So what I did was I tried to see exactly how our unit was performing at that stage. I've now moved back to Belfast, and as such I will only be presenting data from the East Lancashire Hospital Trust. Well, I started in the East Lancashire Hospital Trust in 2015, and one thing that we noted was that our amputation rates increased quite significantly. And I'm not entirely sure whether that is due to our identification of these patients at a late stage, whether it was due to identification of these patients performing an amputation before the patient died from severe sepsis. It's multifactorial, and we never really got to the bottom of this. But what we do know, and as you would expect, we're doing an awful lot of above knee amputations, which unfortunately has a reduction in post-procedural rehabilitation. For my own practice on the National Vascular Registry, which is Freedom of Information, you can see that I've just a generalised range of amputations, and this is really in a 14-month period. However, when we look at this in more detail, we can see that a large proportion of my amputations are diabetic. But if I can draw your attention to, if you look in the bottom graph at outcomes for toe amputations, you can see that I have a very high death rate, which suggests that I'm amputating toes in very sick individuals, and I tended to perform this to minimise infection, but also for analgesic purposes for quality of life. When we look at the global UK National Vascular Registry, we can see a large proportion of patients are men, they're current smokers with associated tissue loss, and there's also a very high proportion of diabetic patients undergoing amputations. So where were we when we looked at time scale from surgery? And again, the national guidelines are suggesting that once a decision is made to proceed to major limb amputation, we should have a timeline of surgery of less than 10 days, usually around 1 week. And actually, unfortunately, we were outside of this and needed to optimise our practice further. However, one thing that I was keen to bolster in our unit is that we had a higher below knee amputation rate than above knee amputation, which meant that we were trying to rehabilitate our patients as much as possible. So what actually are we doing about it? Well, I believe that we are in a position that we can offer the best care that we can. And I have to admit that my training in the Mayo Clinic in America has fostered this ethos of care. To this extent, I really only accepted that I could be surrounded by the A team. So, where were we? Well, in Blackburn, we had two fantastic individuals as part of a global team. We had Jill Lomax, one of our senior podiatrists, and Kath Eccles, our senior nurse, who subsequently retired, and Sue Kenny came on board thereafter, who was a stalwart and one of my close friends in the East Lancashire Hospitals Trust. And together what we thought is we needed a multidisciplinary team approach, and that's classical of requirements in all units as per Specialised Vascular Services from a consensus document in 2014. We needed specialised care providers with passion. We needed to recognise where do our patients come from, and we needed to have open communication and rapid management abilities. So we recruited senior podiatry staff, specialist nurses, diabetologist, orthopaedic surgeon and vascular surgeon with an interest in diabetic foot, and at later stages we also had a microbiologist attending our ward rounds, who actually advised us that she can get organisms and sensitivities 24 hours quicker than what we can on a computerized system. As the laser team evolved, and I must apologise for forgetting to advise what laser team means. Our diabetic laser team is essentially diabetic limbs at serious risk, and that's what we called our team. And towards the end of the first year of this process, patients and their clinicians would have documented in the notes a wait laser team review, which was very reassuring that our overall care ethos and team-based actions were disseminated out through our trust. However, we also got a microbiologist pharmacist who was great for optimising our treatment, and also we introduced training and education with a lot of our trainees, both from nursing and medical backgrounds. So I believe we then had the ultimate A team, and this is one of the things I miss most about leaving to come back home to Belfast. So what do we actually do? Well, we need to identify the patients, and we decided that front of house in our podiatry or specialist nurse is where all our sick patients would filter through. Our podiatrist particularly would identify patients outside of our vascular ward and outside of our diabetic foot ward, and it's these patients who perhaps were admitted for treatment of pneumonia with a known foot ulcer, where the foot ulcer was dressed and then nobody would redress the wound or identify it or even review it, and it's these patients we tried to target with our laser team. It's also important to prioritise the patients, so we would send emails before the round and we would target 3 or 4 patients for rapid expedited evaluation. We reviewed all the patients at bedside. We did not do this around the table remotely. Our diabetologist reviewed all aspects pertaining to medicine, particularly medications. I relished the opportunity to discuss cases with Mr. Barry, who was fantastic as he could advise me real time as to future morphology of the foot following any resection surgery that I would perform, and whether this would be suitable for future mobilisation. And then we also had rapid vascular assessment via our senior nurses, and as I had endovascular privileges in Blackburn, I could proceed to endovascular intervention usually within 24 to 48 hours. So expedited care was fantastic, and we could turn around these patients normally within 24 to 48 hours. So expert review, we had no real administration support, so I personally, as lead for the team, would email the outcomes for all patient reviews, and then we often had crossover from our diabetic orthopaedic and diabetic vascular pathways. So when we reviewed our practice, well, we reviewed nearly 130 patients in a period of nearly 18 months, male predominance in the 7th decade of life, and a lot of patients were frequent flyers who were predominantly diabetic. I must admit that I don't really believe the smoking prevalence of 14.1%. I think this is a gross underestimation. Patients would have marked inflammation with high white cell counts and CRPs, and all patients had a bedside Doppler followed by formal vascular laboratory testing in the majority of patients, which did identify arterial malperfusion, and most patients had osteomyelitis investigated, but 26 had it confirmed on X-ray with MRI occasionally performed as well. All medicines were reviewed, and best medical therapy commenced as required, particularly if we were proceeding to endovascular intervention, and antibiotics, most importantly, was reviewed and rationalised, particularly with single therapy flucloxacillin in a non-resolving diabetic foot sepsis. A total of 48 revascularizations were performed, with the majority being endovascular, and patients did proceed to various limb amputations affecting toe and also major limbs as well. We had a high attrition rate of nearly 30% death rate during the study period, and a lot of patients were also reoperated on or had amputation revision to a higher level. So our initial experience has identified a very high risk patient population presenting with advanced diabetic ischemic pathology. They were really a very difficult population to identify and treat, and a lot of them were relatively non-compliant with all forms of treatment. We do believe a combined multidisciplinary approach did afford rapid investigation and subsequent therapeutic intervention in nearly 60% of total assessments, but this is very labour intensive to try and limit limb loss. But if you look at the long-term socio-economic consequences of limb loss, we still believe that this was worth the effort. So future aspirations, clearly a business plan, some clerical support. We would like to do this on more than one round per week, and to continue with education and perhaps expansion to the community. Fewer amputations is the overall goal though. So we look at some clinical cases, and I'll pause here.